Hi, this is Dr. Bernstein with our October 2020 teleseminar. Before we start answering questions, there are a couple of special subjects I want to go over. The first would be a little bit of an update on COVID-19 and diabetes. There's a group at the University of Alabama and Birmingham who have been experimenting, actually not experimenting, they've observed mortality in COVID-19 patients, and they found that those who were already taking metformin had a 70% lower death rate. So this has not been published in a peer-reviewed journal. It's an announcement. Whether this can be verified by other studies, I do not know. Another new bit of information about COVID-19 is that in addition to having toxic effects on the vascular system, the nervous system, and the heart, they've now found toxic effects upon the thyroid gland. Patients with COVID-19 have been found to have thyroiditis. I'm sure it's not all the patients, but some of them. So that's a new report. Now I'd like to cite one of my experiences in trying to avoid COVID-19 that leads to a warning. We found that a local restaurant had a large patio out back, which they partially enclosed with a huge tent. The sides of the tent were open and the ends of the tent were open. So there was air freely flowing through this beautiful tent. And we went there for dinner and felt safe. The waiters wore masks. The patrons couldn't wear masks because they were eating, but we felt safe. We then went back with some friends a second time, a week later, and this time the same tent was there, but they had put sides on the tent and they had closed the ends of the tent except for a little doorway entrance at each end. So now there's this big, beautiful tent, but it's totally enclosed, filled with tables that were perhaps 4 feet apart, and in my opinion, no longer safe. So we're not going back to this restaurant. Just warning about what may seem like trivia could be pretty substantial, and we're not taking any chances. One other special subject, there have been many requests for the recipe that I created for making your own liquid glucose. I've been using liquid glucose that we purchase in little bottles, but I realize that this is pretty expensive, and there are many diabetics who cannot afford the cost. It costs probably about $1 or $2 a bottle. If you use my recipe, you can make liquid glucose for about 25 cents a bottle, including the plastic bottle. And if you reuse the plastic bottles, your cost would only be probably 10 or 15 cents for a bottle of liquid glucose. So the formula for the liquid glucose, or the recipe, is on display on the screen right now. And if you're not watching our video, you could get it by going on YouTube to Dr. Bernstein's Diabetes Solution, and pick today's video. Okay, we're going to go to questions, but my usual warning that I'm giving generic answers to these questions. It's very hard to give an answer that's going to be valid for the person who submits the question, because I have not examined that person. I have not gotten a complete history. There may be a lot of pertinent information about medications that he or she is taking, supplements, etc., that I know nothing about. So the answers I give are really for the general population of listeners, to give them a little bit of education. And the answers will not necessarily be useful for the person who asks the questions. Now, here's another citation to another authority. Dr. Stephen Gundry claims that type 2 diabetes and many other ailments have been cured in many of his patients who follow his plant paradox program, which removes lectins from their diet. This earns them a healthy microbiome. Do you believe that your program is optimized enough, or else do you think it might be worth exploring the strategies of Dr. Gundry? Again, beware of websites operated by individuals who are selling something. In this case, the doctor is selling foods. So he's selling foods, I guess, that don't have lectins and claiming that they're curing people. So beware of the internet, beware especially of something that's being sold. A low-carb, high-fat diet has been a game changer. I am less insulin resistant, feel better, and have lost weight. However, recently I've noted my blood sugar spiking in the afternoon, and the level doesn't decrease when I take my Humalog, either with my meal or as coverage for a high blood sugar. My blood sugar will stay at a 12 to 16 range, which in American units is 116 to 188 for hours, even when I double or triple the dose. What is happening? Well, first of all, you're using Humalog, which is a rapid-acting insulin that wears off before the digestion of the meal finishes. So that's possibly one cause of your problem. Another possibility is that you switched to a new vial of insulin or a new insulin pen, and the new insulin is spoiled, which is very possible. Also, if you switched from an insulin syringe to an insulin pen, you could be losing the insulin, as I've explained in the past. There's a very high incidence of insulin loss, either leaking out of the injection site or not even getting injected because you didn't hold the button on the pen down long enough. Another possibility is that you may have an infection, which causes severe insulin resistance and could result in the high blood sugars. Most commonly, we find are infections in the mouth, periodontal or endodontal infections. I'm a type 1 diabetic and I use Humalog. How do I change to regular insulin? Well, first of all, you read my book, Diabetes Solution. Humalog is twice as potent as regular insulin, so at least for most people. So you may need double the dose if you're using it to cover food or you're using it to bring down an elevated blood sugar. But since this might be your first time at trying the regular insulin, don't double the dose. Increase the dose, say, by 50% as a trial. And if that doesn't do it, increase it by 75%. So change the dosing gradually, just in case you don't need double the dose. Each person may be different. Can you make a video on making your own liquid glucose? Well, we're submitting the recipe today. COVID-19 and type 1 diabetes, any meaningful data? We just gave some meaningful data. Do you have any recommendations concerning the dawn phenomenon and propranolol instead of a dose of insulin upon arising or a second basal dose at bedtime? Well, I don't know what propranolol would have to do with the dawn phenomenon. Apparently this person is operating under the myth that when you wake up in the morning, you make a lot of adrenaline, and propranolol blocks the effects of adrenaline, and the adrenaline is raising your blood sugar. That is not the cause of the dawn phenomenon. The cause of the dawn phenomenon is the production of growth hormone about 3 hours after you fall asleep, which causes the liver to clear away insulin later on in the night, around the time that you get up in the morning. I cannot find individually wrapped keto sticks. What do you suggest to use instead of those? I noticed that there are ketone meters. Do you approve those? I don't know why you're checking for ketones unless you have a child who is in danger of becoming dehydrated. Being on a low carbohydrate diet does not actually lowers the risk of ketoacidosis and therefore lowers the need for keto sticks. Nevertheless, the keto sticks need not be individually wrapped. In fact, I do not know of any that are individually wrapped. I have them in a vial. I've never used them for myself. I've had diabetes, well-controlled diabetes now, for probably since 1973. The only time my urine is ever tested for ketones is when I collect a 24-hour urine and, amongst other things, order a urine analysis. The thing that comes with it is ketone values, and those are usually 0. So here I've been on a low-carb diet for a long time. When my urine is tested, there are no ketones, and the only time it's necessary to check for ketones is if you have very high blood sugars and dehydration. Now, there's one other possibility. There are some questions about medication for type 2 diabetes called Sgl2 antagonists. And these substances, which cause the kidneys to pour out glucose, lowers blood sugar by dumping the excess glucose in your urine, can also cause ketones in the urine and can also cause dehydration. So if you're taking one of these drugs, there may be a reason for testing your urine for ketones, certainly if you're not feeling well. I take Dex-4 tablets to help bring my glucose up. You mentioned maltodextrin isn't good, yet in the Dex-4 tabs, one of the ingredients is maltodextrin. I'm not sure what to make of the Dex-4 tablets. Well, my warning against maltodextrin is not to use it as a sweetener because it can raise blood sugar. And if there's a little maltodextrin added to the glucose in the Dex-4 tablets, all it's going to do is raise your blood sugar, which is what you want to do anyway. It might work more slowly than the glucose, but the amount that's in the tablet is very small. It's to enhance the taste, and so it's only a small amount. It's the glucose that's going to have the major effect on your blood sugar. So I wouldn't worry about maltodextrin if it's in glucose tablets. During my nighttime sleep, I have hypoglycemia. Trial of wearing Freestyle Libre. My doctor said it is the Somogy effect, and that's why glucose is elevated in the morning. Mind you, my fasting glucose is 4.8 to 5.2, which would be 81 to 94. 4 hours after waking up, it could go to 6.1, which would be 110 in American units. Should I eat before night to prevent night hypo? Well, first of all, the Somogy effect is a myth. I've repeated this in my videos over and over. You may find a special video on the Somogy effect. Usually it's a myth perpetrated, as far as I know, only by endocrinologists. And many of the endocrinologists say that Somogy was from China, where he was really Georg Somogy, who was from Hungary. And this is a myth. You could look for the article. I believe it's in Archives of Internal Medicine, called The Somogy Phenomenon, Sacred Cow or Bull. And the conclusion is that it's bull. And you can have your endocrinologist look it up. I think that instead of using the Freestyle Libre to depend on the Libre for your blood sugars, you should use a continuous glucose monitor that gives you an alarm, and then check your blood sugar yourself, because any of these continuous monitors can be incorrect. They're at the very least 20 minutes to a half an hour behind your glucose meter. So I would be checking my own blood sugars, not going by the recording that the monitor makes. And you ought to read my book, Diabetes Solution, to find out how to avoid the dawn phenomenon. Our diabetes specialist talked about how children especially need a lot of carbohydrates to grow and develop properly. Do you have any word on a very low-carb diet and its effect on child development? The only word that I could think of is the article that was published in the journal Pediatrics, I believe in the year 2018, about the people participating in type 1 GRIT who use a low carbohydrate diet, and they found that the children were growing better than they were before they cut their carbohydrate. However, you might look at the studies done by Bill Tamberlane of Yale in the 1980s, where he found that children with diabetes went off their growth curve, but if their blood sugars were normalized, they went back onto their growth curve. So the important thing is normalizing blood sugar. You don't need carbohydrate for growth because the proteins in your diet can be converted to glucose by a process called gluconeogenesis, which doctors are taught about in medical school. So this diabetes specialist who's talking to you may not have gone to medical school, or if he or she did, doesn't remember his or her biochemistry. You don't recommend Jordiance. Why? Jordiance is an Sgl2 antagonist, the type that I mentioned earlier. And this is a personal prejudice because I'm fearful about the notion of shunting excess glucose through the kidneys at an accelerated rate. I'm just wondering whether this can, over the long pull, 20 years or so, 15 years, 10 years, cause damage to the kidneys. Recent studies of short term show that if anything, kidney function is improved. That is, the activity of the kidneys is increased, the creatinine clearance is said to improve, but that's because you're forcing the kidneys to process more urine. What will be the net result over time, I just don't know. One thing we do know is that there are considerably more amputations amongst people who are given this class of drugs. Now, is this just a coincidence, or is it caused by the drug? I have no idea. You mentioned a topical treatment for Dupertren's contracture. I cannot find a primary or an endo who will write a script for a compounding pharmacy. Well, the treatment is a mixture of collagenase and DMSO. Now, there are hand surgeons who are injecting Dupertren's contractures with collagenase. It's an expensive and painful process. Some of them may be willing to try the mixture with DMSO and have you apply it locally. So the first thing you have to do is find a hand surgeon, and a hand surgeon who treats Dupertren's contracture, and maybe you could interest him in prescribing the collagenase DMSO mixture. And he can experiment with the concentration of collagenase, how much to how much DMSO. The problem here is that he's losing business on the one hand. On the other hand, he's processing you more rapidly. You'll probably have to come back for return visits to see how it's doing. So he may make up some money by having return visits. And of course, once he starts doing this without having to inject people, he may be able to get a lot of business with other people who want to do the same thing. My highest blood sugar is often in the morning, average 119. My postprandial is often under 112. What can I do to have lower morning blood sugars? Well, I suggest you read my book, Diabetes Solution. You might try a low carbohydrate diet. You might Your doctor may want to try some medications, such as metformin. If you're overweight, you may want to lose weight, exercise. There are lots of options. Read the book. My mother is in a cycle of dehydration, diabetes, and chronic urinary tract infections. By the way, this is a potential problem of, this combination is a potential problem of Sgl2 antagonists. How do I stop that? She has been to a urologist and there's nothing medically wrong with her in the kidneys, but he prescribed her a low dose of antibiotics. I don't know what else to do. Well, first of all, she should normalize her blood sugars, because people with high blood sugars have a tendency to have urinary tract infections, especially over older women. And if you want to know how to normalize blood sugars, read my book, Diabetes Solution. My recent lab test showed that my vitamin B12 level was very elevated at 1820. Now normal is 200 to 900. I am 66 years old, type 1 diabetic for 58 years. So this person is a real survivor, and weigh 113 pounds. I also have CVID and hypothyroidism. CVID is the disease that I have and a number of diabetics have, common variable immune deficiency. Could this level be harmful? And what may be causing it? I do not take supplemental vitamin B12. Could the diabetes be part of the reason? Well, first of all, there are many possibilities. For example, there could be liver disease, could be kidney disease. We find high B12 with some solid and blood malignancies. So you'd be wise to see a hematologist, perhaps first, but you may need an oncologist, a cancer doctor, or a kidney doctor. So this really should be checked up. It's not routine for B12 to go up just on account of diabetes. And I don't believe that B12 goes up just on account of CVID. Now, it could be that you may be taking some multivitamins that contain B12, in which case, check the label on the bottle. My son is newly diagnosed with type 1 diabetes. I've changed his diet from a high carbohydrate diet to a lower carbohydrate diet. That doesn't mean that it's low, I don't know. His blood sugar has stabilized, his hands are no longer sweaty, and he is sleeping better. We do not have to give him any insulin during the day anymore. He is feeling great. His ketone levels have gone up. I called and talked to the nurse about this. She told me that it is not a good thing, and that I need to give him more carbs and more insulin so his body could get rid of the ketones. She said that she would rather see high blood sugar and low ketones over low blood sugar and high ketones. Not sure what to do. Well, the first thing I think of when I hear of someone showing ketones in their urine is that they're metabolizing fat. And there could be two reasons why he's metabolizing fat. One could be because he's eating an excessive amount of fat compared to protein. But another and very common reason with kids is that their blood sugars are still high, not normal, and they're losing weight. They're peeing away calories because they're peeing away glucose, and they're losing both muscle and fat. And if you metabolize fat, you're going to have ketones in your urine. So my guess here, and I could be wrong, is that his blood sugars are not normal, they're still elevated, and that he probably needs more insulin and more protein, and that he's probably been losing weight, which you would know better than I. Next questions. Are pork rinds okay? Well, this person doesn't say okay for what. It's not okay for the piggies. But if you're diabetic and include the pork rinds in your computation of protein, they're not going to dramatically affect your blood sugar unless you sit there watching television for hours at night, snacking on pork rinds. Snacking on anything endlessly, if you're diabetic, is going to raise your blood sugar. And even if you're not diabetic, although snacking on pork rinds won't do fat as rapidly as snacking on pretzels will, they'll probably eventually do the job if you sit there eating them all night. Are you still mainly not for pumps? Well, if you're on a pump, I would suggest that you look at your blood sugars and that you check them, especially 1 and 2 hours after meals, but also when you get up in the morning and several times during the day, and see if they're normal. If you're an adult, I would think that normal blood sugars would be about 83 milligrams per deciliter. And my bet is that your blood sugars are nowhere near that. And if you've had a pump for a long period of time, they're further away than they were when you had the pump for a short period of time. And the reasons for this you could read in my book, Diabetes Solution. At what blood sugar do you suggest we make a correction? Low and high. Well, again, it all depends on a lot of things, and there's not a simple answer. When it comes to corrections of high blood sugars, it's not just what the blood sugar is, but how long after the last shot of rapid-acting insulin. And that's explained in my book, Diabetes Solution. When it comes to low blood sugars, it has to do with the size of the dose of glucose that it's convenient for you to take. I use a shot glass, and it's calibrated in teaspoons, and 1 teaspoon will raise my blood sugar by 12. So if my blood sugar is 12 below my target of 83, I'll certainly make a correction. I may try to take a half a teaspoon if it's 6 below my target of 83. On the other hand, with correcting high targets, it depends how much a unit of insulin will lower you, or a half unit if you have half-unit syringes. And most of my patients are taking diluted insulin for corrections, so that one diluted unit might lower them by 15, and a half a diluted unit might lower them by 8. So they'd make a correction if there were 8 above their target. Fiasp insulin. We know your experience with the other 3 rapid-acting insulins, Humalog, Novolog, and Apidra, but nothing yet on Fiasp. except for claims made by Novo Nordisk. Is it really faster? Does it last the same? Does it reduce blood sugars the same, more or less than aspart? Aspart would be Novolog. Well, Fiasp is Novolog with added citric acid and L-arginine. Citric acid is supposed to increase the permeability of blood vessels, and L-arginine is supposed to relax blood vessels so that they stretch more, making the membrane thinner so that insulin could get through the membrane easier. It also makes the pores bigger so insulin can get in through the pores in the blood vessels. I have not experimented with it. I could mention some experiments we've done with inhaled insulin. I think I'll save them for a subsequent video and teleseminar. For someone with gastroparesis, can the Chinese restaurant effect also become delayed for days? Well, it's a good question. If you have very significant gastroparesis, it's frequently difficult to distinguish between gastroparesis and the Chinese restaurant effect. For example, you find a person with gastroparesis who, after dinner, has a low blood sugar, and then the next morning the blood sugar is very high. It's as if the dinner did not empty when it was supposed to, and emptied overnight the next morning. Very slow stomach emptying. On the other hand, the protein that you ate for dinner, well, I should say the bulk of what you ate for dinner should raise your blood sugar, and that's a short-term effect. So that could offset the low blood sugar caused by the gastroparesis, so you don't notice it. Because if you distend your duodenum, you're going to make, the intestines will make hormones that'll cause the production of glucagon that'll raise your blood sugar. So here, what you ate for your meal could short-term raise your blood sugar just by being in your intestines, not even by getting into your bloodstream, and offset the low that the gastroparesis would give. So it could confuse things. I am 32 years old. I've been diagnosed with type 1 diabetes for 15 years. I keep my blood sugar around 100 to 110 milligrams per deciliter. From January 2019, I began to have visible edema in the lower and upper limbs. The lipid profile and renal profile are in range. My A1C is 6.5%. Well, that's pretty high. That's an average blood sugar of 160 milligrams per deciliter, which is double normal. Now, this person has certainly had diabetes long enough to cause kidney disease, especially since his blood sugars are averaging double normal. So it could also, the edema could be caused by a loss of protein from the blood into the urine. It can be caused by taking certain medications, such as Actos, I would think that you should probably see a nephrologist and get kidney studies, 24-hour urine, and a number of other tests. I had to do an analytic, I guess that's a blood test, on July 6th and tried to see if everything else is fine. I also have hypothyroidism, vitiligo, gastric atrophy, low B12, and cholesterol. Can your method help with all these autoimmune complications? Probably not. It can help the diabetes. And it can help not with the cholesterol, but it can help with cardiac risk factors such as small dense LDL, low HDL, oxidized LDL, glycated LDL. The total cholesterol has no relevance to heart disease, although I think there were some studies that showed higher suicides in people with low cholesterol. A very ancient study. Has hemoglobin A1C test in 2 different labs at the same day. Had A1C tests in 2 labs on the same day. One reported 5.6%, and the other reported 6.0%. Confused and lost on what to believe. Please advise. Well, first of all, there are commercial kits that are sold to the laboratories for measuring hemoglobin A1C. They're chemical kits. And 2 laboratories may purchase different kits and therefore have different values. So that's a real possibility. I would say go by your own blood sugar measurements when evaluating your blood sugar control. If you do frequent blood sugars, especially after meals, you'll have a better and more up-to-date evaluation of your blood sugar control. Have you heard of the plant-based high carbohydrate diet encouraged by the Mastering Diabetes program? They claim it reverses insulin resistance. I read your book and don't understand how these 2 diametrically opposed ideas can exist in the science world. I'd love to hear your thoughts. Well, here again, I warn you about people who are selling things on the internet. Nowadays, it's about the only way you can sell things. They are selling our coaching program, which is probably extremely expensive. And I imagine it's very profitable for them, and I doubt that it would be profitable for you. Beware of people who sell on the internet. Recently diagnosed with MODY, that's maturity onset diabetes of youth. I'm currently on a low-carb diet with 3 units of Tresiba per day. My A1C is 5.4%. That's an average blood sugar of about 116. And I'm being encouraged to switch to a sulfonylurea instead. My concern is, what is the point of making this transition if the most likely scenario is to return to insulin a few years down the line? Well, first of all, if your average blood sugar is 116, you should be doing something to get it lower. It would be nice to get all your blood sugars down to around 83, and to preserve your beta cells. Now, sulfonylureas long ago were discovered to burn out beta cells. In fact, if you look at the package insert, there's a good chance that it says that you shouldn't expect it to work for more than 2 years. And why does it stop working after 2 years? Because it's burned out the beta cells. Sulfonylureas stimulate the pancreas to make more insulin, and it eventually burns out the beta cells. There also is evidence that it interferes with an enzyme in cardiac function, and can be a cause of heart disease. What is the best way to treat neuropathy in feet? Normal blood sugars. We've seen, first of all, the neuropathy can appear in many aspects. It can appear as painful feet, as numb feet, as extremely dry skin, as deformity of the feet, as calluses caused by deformed feet, etc. Even infections in feet caused by attempts to remove the calluses, etc. So the best way to treat the neuropathy is to normalize blood sugars. And in fact, in my book, Diabetes Solution, there's a section, what to expect after your blood sugars are normalized. And one of the things is the return of sensation in the feet. I was diagnosed with type 2 with strict carb control. I lost 40 pounds and my A1C is hovering around 5.5. That's about an average blood sugar of 120. I have hit plateau. To stay around your recommendation of average blood sugar of 83, will there be any doctor who would prescribe me meds or insulin to reduce my blood sugars further? Well, before you need meds, you might look into exercising strenuously. Of course, if you have a heart condition, you have to watch out for that, so it has to be supervised by a physician. So exercise. If you're still overweight, losing weight can help your blood sugars. There are oral agents which can treat type 2 diabetes. Things like metformin, Avandia, and you may not need insulin. If none of the oral agents work and the exercise, etc., doesn't work, there's the possibility of using either diluted insulin or very small doses of a long-acting insulin like Tresiba, like a half a unit a day or something like that. But consult with a physician. In all likelihood, an endocrinologist will not want to get your A1C under 5.5 because the ADA says that an A1C of 6.7 is normal. So, and the endocrinologists, many of them are afraid of the ADA and are afraid of lawsuits, etc. So you might be wise to have a family practice physician guiding you in medications that might lower your blood sugars further. Do you see a strong link between the hormone insulin and cancer, or an even more worrisome link between the analog insulins and cancer, and are diabetics at higher cancer risk? Well, first of all, there have been several studies that have found diabetics to be at higher cancer risk than the general population. That's number one. Number two, I know from my experience with patients whom I've tested that about 25% of my patients have diminished antibodies, typical of common variable immune deficiency, but only about 10% of these actually require supplemental gamma globulin. However, 3 patients who had low IgM and immunoglobulin had head and neck cancers. That's sort of worrisome. So it could be that the small percentage of patients with significant immune deficiencies that have cancers may affect the statistic. Another is the studies of Lantus insulin, which in European countries with national health insurance, and in I believe 3 of the countries, the Lantus use was associated with cancers. I read your book, and as explained in the chapter Gastroparesis, it's very much like GERD. Please explain the difference. Pre-diabetic for 1.5 years, also diagnosed with weak lower esophageal sphincter. High protein diet causes a lot of stomach belching. Well, gastroparesis tends to cause a tight lower esophageal sphincter, so that food gets stuck in the esophagus, doesn't go down into the stomach, or doesn't go down rapidly enough into the stomach. This person has a weak lower esophageal sphincter, so food gets into the stomach very easily. And if the high protein diet causes a lot of stomach bloating, it's probably because the protein gets into the stomach and loads it up rapidly because the lower esophageal sphincter is wide open. That's just a guess. It could be totally wrong. Now, to differentiate between the two, and you might have both, you could have your doctor prescribe Motilium, which is available in Canada, and can relax the lower esophageal sphincter and speed up emptying, and it's a treatment for gastroparesis. So if it makes your problems worse, you may not have gastroparesis. My guess is you don't have gastroparesis if you already have a diagnosis of another condition. I have a question regarding the cyclical ketogenic diet, where you do a low-carb diet for 10 days, and then on the 10th day you eat carbs. Do you think it's a good thing for people who are looking for extra motivation to do low carb? Well, since carbohydrate craving is an addiction, like with any addiction, the more you're exposed to the carbohydrates, the more likely you are to crave them. So to stop them for 10 days, where maybe you're beginning to lose your craving, and now you bomb yourself with carbohydrate, you're gonna the chances are you'll never get over the addiction. That's my point of view. Also, on the 11th day when you eat all the carbohydrate, if you're diabetic, your blood sugars are going to go sky high. "35-year-old male, type 1 for 21 years, always been reasonably controlled, and in the last 5 years my A1Cs have been between 6 and 7%. So that's between 140 and 180 milligrams per deciliter, which at the high end is more than double normal. So that's not well controlled at all. I've noticed a sharp decrease in my insulin needs. The only events in my life related to my health that I can think of during the last months are 3. The lockdown. Here in Italy, it's been 2 full months, and its impact on decreasing my usual exercise levels. 2 months ago, I went to a session of hydrocolon therapy for the first time in my life, which was very alleviating. I wonder what that means. And 3, in the last few weeks, I've been sunbathing quite more than I'm used to. Is it possible that somehow my pancreas started working more than usual, if at all it was working? Or could this be a sign of some other disease, or simply I've become much insulin sensitive? Well, this is a tough one. It could be that you changed your diet during the COVID epidemic and getting less carbohydrate. It could be that maybe you had an infection such as a tooth infection that improved, because infections can cause high insulin requirements. Another thing that's a possibility, maybe a remote possibility, I have to look up the word that you were using. Whatever you did to the colon, the hydrocolon therapy. The hydrocolon therapy could have changed your microbiome, the nature of the bacteria living in your gut. The microbiome has evolved with you over your lifetime, and there are certain interventions that can change the microbiome. Antibiotics can destroy many of the organisms in the microbiome. Probiotics can substitute new microorganisms which might or might not destroy the microorganisms that are already there. The hydrocolon might have destroyed some microorganisms, and maybe, and we know that the microbiome affects many systems of the body, affects the nervous system, affects the endocrine system, and could also affect insulin resistance. So it could be that you had a big change in the microbiome, and somehow you need less insulin. There's so much about the microbiome that we don't know. It's this big new mystery that many scientists are investigating. Well, thanks for listening and watching. Our November teleseminar will be available on Wednesday, the 25th of November, 2020. We'll look for you then. Thanks.